Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody. Thanks for tuning in for Direct Connection. Later in our program tonight, advances in telemedicine and how patients can benefit. But first tonight, the medical detective work of fighting the Ebola virus. Joining us now is infectious disease expert Alan Cross, a professor of medicine at the University of Maryland School of Medicine. Dr. Cross, thank you for being with us.
Thank you for having me.
On the subject of Ebola, do we know exactly how easily it spreads or how easily maybe it doesn't spread?
Well, we've learned a lot from the experience we've had so far since 1976, and the experience we've had so far tells us that it's spread by direct contact, usually with body fluids, sweat, blood, vomitus, diarrhea. And however, it is not spread, it hasn't been, by the respiratory route. So it really takes direct contact with a person who has it.
Part of the fear here is that the two nurses in Dallas, it's not really clear yet just what went wrong in those cases.
Well, that's true. I think that what's going on now is a review of the protocols by which they were operating, and I think that Dr. Frieden at the CDC has issued a update of that protocol in which he indicated that all of the body parts ought to be covered by protective gear when taking care of these patients. Apparently, some of those nurses had some exposed skin.
Yeah, I heard, maybe it was on one of the talk shows over the weekend, I heard it said that one of the reasons maybe the exposures happened here is that in U.S. hospitals, as opposed to the clinics in Africa that have the most experience with dealing with this, Doctors Without Borders and so forth, more invasive procedures were being used. A patient was being intubated, or a lot of blood work or dialysis and so forth. Does that make sense?
Well, that's a concern if we deal with patients in the intensive care units. I don't know what types of invasive procedures that Mr. Duncan may have had, but certainly that is a risk factor here, but I'm not sure that was traced to actually what happened with these nurses.
I guess one of the things that's especially scaring for or causes concern for the general public is the idea that people in the healthcare setting have to wear this, biohazard containment suit, and that somehow you think about how AIDS is or HIV is transmitted. You sort of need blood to blood, as I understand it. In this case, something less than that can transmit the virus, right?
Well, yes. I mean, the problem is in sweat. I mean, we learned just very recently that the sweat of a victim.
And this is somebody in full-blown Ebola.
That's right.
Yeah.
And part of the problem in Africa is that in burying the people who have died of Ebola, people had been handling the bodies and through the contact just with the sweat on the skin has been a source of transmission. So,
but how do they, I mean, say you did that, say you got it on your hands. If you had the HIV virus on your hands, as I understand it, and you didn't have any cuts, you wouldn't get AIDS.
That's right. So the Ebola virus is very different from the AIDS virus in that respect. It's much more directly transmissible from body fluids.
Let me remind our viewers, if you have a question about Ebola, how it is spread, or the treatment of it, you can give us a call. We'll have the number up on the screen. You could also tweet a question. Our Twitter address is @MPT News. What is happening on the treatment front? I imagine we're learning a lot about it pretty quickly.
Yes. Actually, there's lots of work being done in terms of not just vaccines, but various treatments. We heard, of course, about our two missionary doctors who came back here infected with Ebola and got an experimental treatment that was made out of antibodies from a small company in Kentucky, and that treatment really exhausted their supply.
And in terms of just the normal procedures that an ICU would follow in treating symptoms and sustaining life, what's being learned about the process and preventing somebody from getting into that end stage condition?
Well, there aren't any specific therapies, unfortunately, for Ebola virus. And I have to really underscore that these patients have to be treated in a high containment facility. So there aren't very many of these around. We know that the patients who have come here have gone either to Nebraska, Emory, or at the NIH, where we have those facilities. But these patients would not normally and shouldn't be cared for in a hospital that is less than high containment.
Let's take a phone call. This is Nick in Anne Arundel County. Nick, thanks for the call. Go ahead.
Yes, thank you. I have a question for the doctor regarding the Ebola virus, of course.
Sure.
The question is this. Has there been any evidence that this virus, Ebola, has mutated from its original detected form in 1976 to the present day? And if it hasn't, why not?
Nick, thank you.
Well, actually, it has mutated, but however, it hasn't really changed its basic character. So scientists have been able to actually examine the genes of all the viruses that have been isolated from the patients, and they have found mutations. But I want to stress that there has been some talk about having possible mutations that would change the basic character such that it might be spread by the respiratory route. And so far, it's really extremely unlikely that that would happen.
One of the important things about this is that apparently somebody who's in the process of coming down with it, we think about the airport screening
Yes.
procedures where they're taking temperatures and medical histories and travel histories, that supposedly you're not contagious at all until you're symptomatic.
Yes.
And you think about other conditions, I don't know if it's the flu or the common cold, where you've always heard that somebody was contagious
Yes.
before they were symptomatic.
Yes. Well, here it's different. So far, that this really has to be confirmed, but the contagiousness in part has to do with what's called the viral load, how many viral particles you have. And when you're asymptomatic, your viral load is much lower. Once the symptoms occur, it means that your viral load is much increased, and it's at that point that your secretions are much more infectious.
Let's take another call. This is Richard in Anne Arundel County. Richard, thanks for calling. Go ahead.
Yes, I was going to ask you, today's news indicated that the family that was of the deceased man in Texas have all been cleared today, and they had close proximity, including the fiance. Isn't that good news that at this point they've all been cleared, and that even though they were so close to him, that no one came down with the Ebola?
Richard, thank you.
It's very good news, and the expectation is that if a person that has contact with the case has not come down with any symptoms by 21 days, it's extremely unlikely that they will. So it is very good news indeed.
What's happening on the vaccine front? I mean, is it with your background in infectious diseases, is this the sort of condition for which a vaccine is likely to work?
Absolutely. The idea is that if we had a vaccine, it certainly would protect frontline workers, especially those Doctors Without Borders, a lot of our missionaries. There is a vaccine trial going on right now in 3 African countries. Our center at Maryland, the Center for Vaccine Development, has one such site in Mali, and those studies are ongoing. The hope is that if this vaccine is, first of all, shown to be safe and induce antibodies, then it will go through a next phase where it will be seen whether or not it's effective in preventing cases.
Let's go out to York County, Pennsylvania. This is Barbara. Barbara, thanks for the call. Go ahead.
Hello. Thank you for taking my call.
Our pleasure.
I have a thought. I heard recently that in males, in the sexual reproductive organs, that this virus can be held live for as long as 2 months. And I don't know if this is true. Correct me. And if this would be the case, couldn't this be a very critical sexual transmission? If it doesn't show up perhaps as quickly as it would through touching of sweat or other wet matter.
I understand. Barbara, thank you very much.
Yes.
Well, I haven't heard that. I'll just emphasize that there's a lot we have to learn about the virus, and part of it is because it's so difficult to study. It really has to be studied in a high containment facility as well. So it isn't a case where lots of researchers are doing work on this.
Is there anything that can be done in a healthcare setting, and you think about the really courageous people working at NIH and other places dealing with patients who have this pretty horrible condition? Say somebody gets splattered or there's some break in protocol. Is there anything you can do for them, in the case where somebody's been stuck with a needle or something, to help them maybe not get it? Antiviral drugs, any of that work?
Well, there are lots of experimental therapies, none of which have been tried so far in any test to see if it's efficacious. But there are lots of experimental drugs that which are being tested, and all we have so far are the early tests in non-human primates.
Yeah, on the low-tech end of precautionary medicine, does Purell hand sanitizer actually work on this?
No, actually, I think you'd have to use something like bleach.
Okay. but that's what they use when they're sterilizing something. Bleach.
Yes, absolutely, yeah. Yes.
All right, run on bleach. Let's take a call from Frederick County. This is Elizabeth. Thank you very much for the call. Elizabeth, go ahead. Elizabeth, are you there? We'll wait a second for the delay to go through. Elizabeth, can you hear me? All right, thanks very much. What do you think about the people who are nervous about travel? You read about the nurse who was on, I think it was Frontier Airlines, and then the plane goes all over the place and a ton of people sit in the same seat or neighboring seats. Sounds like they really don't have a whole lot to worry about.
Unless a person is symptomatic, there isn't a lot to worry about. And even if you're on an airplane with a person who's symptomatic, from what we know now, unless you have contact with that person, it's not going to be spread through the air system.
The other encouraging thing, before we leave this, is what's happened in, I think, Nigeria, where there was a case, maybe there was an outbreak, and it's been contained and eradicated there.
The person who has had the case contained. Also, I'd want to point out that the 3 countries involved in West Africa that have had the virus, there hasn't been a significant spread to other countries despite extremely porous borders. So I think that's also encouraging.
Very good. Dr. Alan Cross, University of Maryland School of Medicine. Doctor, thanks for coming by.
Thank you for having me.
We appreciate it. Just ahead tonight, your questions about the growth of telemedicine. We'll be right back.
Tonight on MPT.
Antiques Roadshow is in Jacksonville, Florida. What did we find in the Sunshine State?
This is the nicest example of pyrography we've seen.
Yes!
Your wife is going to be pleased.
That's an understatement.
That's the most fantastic thing I have gotten to hold in the time I've been on Roadshow.
Don't miss these discoveries and many more next time on Antiques Roadshow.
Tonight at 8 on MPT.
Next time on Father Brown.
I must confess I'm intrigued as to why you've invited me here today.
A poet living with his wife and his mistress kills himself.
He was a good man, but I'm afraid his soul was in torment.
But Father Brown isn't buying it.
I'm afraid Mr. Quinton could not have hanged himself.
Murdered. And his involvement angers Inspector Valentine.
This is a murder investigation. Perhaps you could leave the questions to me.
Father Brown.
Tonight at 10 on MPT.
Tonight on MPT2.
On Masterpiece Mystery.
He's a perfect psychopath.
Lewis put away the wrong man. I lost 13 years of my life, and I'm not ever going to let him forget about it. I'll get to say hello in person soon enough, won't I?
I've got one officer dead, another in intensive care. I need my best team on this. The reputation of the whole force is on the line.
I didn't put away the wrong man.
Be seeing you, Laurie. How did you get your number?
Inspector Lewis on Masterpiece Mystery.
Tonight at 8 on MPT2.
Joining us in the studio for this week's Your Health segment is Dr. Mark Zubrow, Assistant Professor of Medicine at the University of Maryland School of Medicine, Vice President of Telemedicine at the University of Maryland Medical System, and Medical Director of the University of Maryland's eCare program. Doctor, thank you for being with us.
Thanks for having me.
We want to talk about telemedicine and tele-ICUs. Let's start broadly with telemedicine. What does it mean?
Telemedicine means the delivery of health care using some form of telecommunication technology to actually deliver care. In contrast with telehealth, which could be an educational program, such as a public service program about breast cancer screening for everyone, not just for an individual.
And the booming thing where the latest smartphones will help you take your pulse and blood pressure and how many calories you burned and all that stuff.
I think it's a very exciting time. There's a lot of technology that's coming out. I'm not sure we know how useful some of those self-monitoring devices are, but it does capture the attention, shall we say.
So your medical specialty, we should say, is an intensivist.
Yes.
So specializing in intensive care patients. And the tele-ICU is applying technology. This is I guess the souped up version of what the iPhone hopes to be when it grows up, using technology to improve the monitoring and care of those patients.
Absolutely. We have a huge national shortage of intensivists or critical care physicians. Every hospital cannot staff 24 hours a day. I think it's fairly intuitive, and actually research has shown that patients do better in intensive care units who are managed by intensivists. And this is a way of leveraging technology to have an intensivist, one intensivist up at night to take care of 10 hospitals rather than 10 intensivists up in 10 different hospitals.
I guess people assume that the intensive care unit of a hospital has a doctor there all the time, or hopefully a specialist in intensive care medicine, but at smaller hospitals, that may not be the case.
Absolutely correct. At smaller hospitals, that is not the case. Again, there is a significant shortage of these physicians. Smaller hospitals can't necessarily afford to staff 24 hours a day, and having the ability to provide that level of support is very important. The larger university centers cannot take all these patients in. People would say, why don't we transfer everybody to Baltimore? There aren't enough intensive care unit beds, and the families don't want to have to travel to Baltimore 2, 3, 4 hours away. And they want confidence in their local hospitals that they can care for their loved ones. It's a great merging.
So let's drill into how it works a little bit. So you're the doctor on call, and there's a bank of monitors, and there's a patient in a remote hospital somewhere. What do you do? And maybe something comes up, maybe something doesn't. What's the relationship?
So there are actually two levels of support. One is the computer has very sophisticated software that monitors the patients. People will say to me, how do I keep track of 100 patients? I don't. The computer does. So every 3 minutes, the computer will run a number of mathematical algorithms to see if the patient's staying within the prescribed boundaries. If not, we get an electronic signal saying, maybe look at this patient. We also have the other side of it where if the bedside caregiver notices something wrong with the patient or the patient's deviating from the expected path, he or she can then contact us and we can camera into the room, have a conversation, review the data. We can see the x-rays, CAT scans. Obviously, we can see the patient and all the machinery around the patient and develop a game plan to alleviate or mitigate whatever has deviated from the expected path.
All things being equal, I'm guessing you'd rather be there in person.
Absolutely.
You'd rather be able to touch the patient, see the patient.
Yes, I mean, in a perfect world, we would rather touch the patient. Technology is getting better and better, so we use a lot of different technologies to, again, mitigate that. So instead of putting a stethoscope on somebody's chest, we might use an ultrasound machine and view the images remotely. And we use that sort of technology to kind of take the place of standing at the bedside.
Who's on the other end? Who is standing at the bedside?
It depends on the hospital situation, but many times it's a nurse and a respiratory therapist. Most hospitals will have a pharmacist available at night to help with medication calculations. It's a team effort in the intensive care unit, and we utilize all these people at night as well as during the day.
Tell me a success story, a time when you were on duty, something came up, and how that went down.
Well, I think the best story we've had, I typically start at 6:30 in the morning, and came in one morning and my doc said, "Hey, we just got this young kid and he's just really doing terrible." And I stood behind her, we cameraed in together, and we worked as a team with the bedside team. And it turned out that this was a sailor who was on leave, and he had contracted a very unusual infection called leptospirosis. And it was pretty clear that he was not going to do well where he was, so we were able to help start the resuscitation at the local hospital while we made arrangements to get him to a major center to get him on what we call ECMO. And he is back on active duty now, so it was a great story.
Let's take a phone call. Anne Arundel County, this is Chuck. Chuck, thank you for calling. Go ahead.
Yes, I'm very intrigued with telemedicine and the opportunity to apply it to disaster planning and a way to make local communities more resilient. And so my question is this: could we use telemedicine to take our medical personnel and our medical specialists and share them out across local hospitals and clinics all across the country instead of amalgamating them in large urban centers, so that those specialists themselves can be distributed and then collaborate because of telemedicine, so that you can have the efficiencies and benefits of collaborative urban hospitals virtually,
Chuck,
so that all our hospitals aren't in just one place, or all our doctors are not just in one place.
Yes, sir. Thank you for the phone call.
Yeah, absolutely. We can do that. We have the technical skill. We have the physician know-how. There are regulatory constraints. And there actually is a bill in Congress now about national credentialing and licensure, but in a disaster situation where we sometimes will have a laxing of laws, if that's English, and it is certainly doable, and we do it now.
What's the network like when you're on duty? How many hospitals? And I was going to ask where they are, but it doesn't really matter at all where they are, does it?
It does not matter where they are. Right now, we're in 10 hospitals all over the state of Maryland. Pretty much every ICU bed on the Eastern Shore is under the camera at our facility.
Where's all this heading, do you think?
Well, I think with regard to tele-ICU, I think this is well entrenched. There are probably over 60 cores or central operation rooms like we have at Maryland and around the country. I think as technology gets better, we'll be able to deliver more care remotely or virtually, and it will certainly move into the outpatient arena. It will move into subacute care and our nursing homes, and I think, as Chuck just alluded to, we'll be able to get a specialist to the patient virtually very quickly.
In just a couple of seconds, do the patients, do their families understand, appreciate what's going on?
Oh, I think they do. We hate to say never, but we've never had a family that was not appreciative at 3 o'clock in the morning, they're watching their loved one potentially have a catastrophic illness that could lead to their demise. And the options are, we can try and call somebody who's asleep at home, or we have to camera in for them.
Doctor, thank you very much for the time. We appreciate it. Thank you for watching Direct Connection, and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.